Debbie's all set. Before you go.
Hi, everybody. We are finally getting ready to get underway for the May 2021 Caseload Estimating Conference. Today is a day of testimony from the Department of Human Services and the Executive Office of Health and Human Services. We apologize for the delay. We had some technical difficulties, but we will be ready to get started with DHS. I just want to check that everybody's back and ready to roll. I see people on the screen. Joe, the other principal from the budget office, is here, and we can start with Director Hawkins if you're ready to go. Welcome.
I think so. Can you hear me? Yeah. Okay. I'm going to be brief, especially now that we're short on time, but I wanted to start by kicking off and saying thank you to everyone on the call today for all the work that you've done over the past year and since we were last together for caseload. As you all know, the Department of DHS has done substantial and significant work to support vulnerable families and individuals in Rhode Island during the COVID-19 pandemic, and I'm extremely proud, as usual, of the work of the team, and you'll hear about some of that today. We're now focused on moving forward and thinking about how DHS plays a role in the recovery of our state, and our program administrators will talk a little bit about that as it relates to their programs, but we're also thinking about that in terms of our operations. COVID-19 has given us the opportunity to make some improvements to the way we operate DHS, and we don't want to lose sight of that. We don't want to go back to the way things were before. We want to be sure that we are taking what we've learned to be stronger and provide better service, look at where we still have gaps, and use what we've learned to fulfill those gaps. So our focus is on the future now and thinking about what the department will look like in the year to come, and we look forward to keeping you all updated on that as we move forward. I wanted to highlight a few significant accomplishments since the last time we were together. Again, Rhode Island was a leader in the reestablishment of the pandemic EBT program in January for school-aged children. This served both families that receive SNAP and families that don't receive SNAP but are free or reduced price lunch eligible. And in May, we will start issuing that benefit to households who have children under the age of 6 in accordance with FNS's more recent guidance. Additionally, this month, we've increased the supplemental benefit to SNAP households. This was rolled out by FNS and have now increased a monthly supplement to at least $95 per household. And that will be rolling out in the coming weeks. You will hear from Hannah Hansen, our child care administrator, about a number of mitigations that we've made in the child care space. I am so proud of how Rhode Island has fared as compared to other states as it relates to the strength of our child care system through COVID-19. And I believe that's directly related to the payment and regulatory mitigations that were implemented by our team. In late March, we started to receive applications for a new stabilization fund that will provide additional grants to child care providers to help alleviate some of the economic and operational hardships they've faced. And as of April 15th, nearly 60% of eligible providers had applied, and 133 had already received award letters, and the team will provide you more of an update on that. In total, just over $2 million has gone out of that fund, and we will continue to process applications. You're also going to hear from Kim Roush about our Rhode Island Works program. We continue to be concerned about the reduction of the caseload there, and the team has done some good work since the last caseload conference to understand what's happening and to be sure that we can find the vulnerable families that should be benefiting from that program and get them back on the program in the months to come. We also know that that program is going to be critical as part of the state's recovery, and as the program providers can provide job training and other support services to families to help them benefit from all of the economic recovery activities that will be happening in months to come. So before I turn it over to Kim Roush, I also just wanted to take a moment to acknowledge that I think this is going to be Janice Cataldo's final caseload conference as she is nearing retirement. And although all of us are frantically holding her by her ankles, I think we are all also incredibly excited for her as she moves into the next phase of whatever she'll do. And I just wanted to say in front of this group, because we won't get to do it in person, thank you to Janice for being such a tremendous support to this department, to other departments, and to me personally. I would not have been the director that I am without her. And she will always be someone who I will remember as a mentor in my life, and look forward to retirement, Janice, and engaging with her in that way. If at nothing else, as at a minimum, I expect my daughter Amelia to be spending a lot of time with her in the years to come. So I wanted to say that, and with that, I will turn it over to Kim Roush, who will take us through the Rhode Island Works departmental information. Thank you.
I'm sorry, can I just stop you for 1 minute? I just want to remind anybody watching that the materials you're about to present from are all posted on the General Assembly's website. You can reach the May Revenue and Caseload Estimating Conference link in the bottom right quadrant of the homepage of the General Assembly. So everything that's being presented today is posted there for people to look at. And just a reminder that anyone on the WebEx to please mute yourself unless you then raise your hand to be recognized. And that will cut down on any feedback. So sorry for the interruption. Go ahead, Kim. Thanks.
Thank you, Director Hawkins, and thank you, conferees. Good morning. My name is Kimberly Roush. I'm the Rhode Island Works Administrator for the Department of Human Services. As the Director just spoke to, the Rhode Island Works caseload has decreased 50% in the past year. COVID has had a significant impact to this population. The document before you does not account for any of the pending legislation or budget articles that have been presented. However, I do want to state that there is a great need for a benefit increase, as it has been very clear during COVID. During this pandemic, instead of increasing access to Rhode Island Works, DHS has lost more than half of the families that we serve. We're now the lowest benefit in New England for cash assistance, and we have the longest sustained benefit amount for being over 30 years without a change. Recently, DHS has been reviewing our caseload and truly analyzing why we've had such a significant drop in cases. We've been looking at earned income, unearned income, and not returning documents to DHS. While unemployment insurance and PUA, as well as earned income, are easily tracked both within our system and through our federal and state partners, DHS has also seen a large increase in customers struggling to return documents to DHS. An unintended effect of DHS's need to close our lobbies for the safety of our staff and the benefit of our recipients or customers. These unintended effects are being addressed by support to our valued Rhode Island Works vendors who are in a very good position to help our customers, not only with applications, but with returning documents to DHS. So that's an expanded service we've been providing through our vendors, and we're going to be expanding on that in the months to come, especially as PUA ends in September. On page 7 of the testimony, what you're going to see is that child-only cases have maintained their numbers, which has largely increased their percentage, while one-parent and two-parent cases have lost benefits. This is due to child-only cases not being required to engage in an employment plan. They have fewer paperwork needs. They typically have a more stable income source, which is SSI or Social Security, and they have an ability to maintain benefits, while our parents that have been struggling the most have had a harder time maintaining benefits. You're going to see through the projections on page 8 that we're going to see a large onboarding of cases as being expected after pandemic unemployment insurance ends on September 6th. Then you're going to see a gradual 2% increase through state fiscal year 2022. The way that Rhode Island Works statute is set is that folks and families cannot access the benefit until after they are under 100%, after they're under about 30% of FPL, or that they have under $1,000 worth of assets. So we have to wait for folks to be able to be in absolute desperate strait in order to access the Rhode Island Work benefits as it stands in legislation today. On page 13, you're going to see how the document outlines that Rhode Island is receiving funds from the American Rescue Plan Act directly from the TANF folks in the federal government. What this means is that DHS will receive $2.7 million in federal funds that have to be assigned through a one-time non-reoccurring payment. DHS expects to use those funds for a one-time payment to SNAP families under 100% of FPL. On page 17 of the testimony, you'll see where MOE is described, and there was a large difference from how we had to calculate MOE through state fiscal year 2020. These were due to increase from ACF about our DCY of spending. So we've been analyzing our DCY of spending both with our MOE expenditures as well as our standard TANF expenditures. We've been making sure that those are allowable, and we're making sure we're maintaining enough general revenue funds to fulfill MOE as we had a drastic decline in allowable expenditures due to the change of calculation in 2020. On page 20, you'll see the overview of the Rhode Island Works contracted vendors. They're fully active. They're supporting our customers and engagement with their employment plans. They're able to do virtual trainings, workshops, and gain employment through the activities that they've been able to do over the course of the year, not only virtually, but a handful of in-person interactions as needed. We also are looking to expand our ability to do virtual work in combination with virtual career centers and virtual meetings with employers, which have been very successful over the last few months. We're going to be going through this summer and transitioning to more in-person activities and in-person events. And as mentioned before, the organizations that are doing our Rhode Island Works contracts and our loyal vendors are also providing those additional services to customers applying for Rhode Island Works. I'll pause for a moment for anybody to ask questions about the testimony provided to you today.
Joe, you all set?
Sure, I have a question. So in terms of the return to eligibility and enrollment in October this year, so following the end of pandemic unemployment assistance, is that right? Can you provide some background as to how you arrived at your estimate of how quickly individuals would return?
Sure. So what's expected is that on September 6th, pandemic unemployment insurance will stop according to the federal rules as it stands today. Department of Labor has not provided any information on an expected extension to PUA. So what will happen is clients will no longer be able to receive benefits through unemployment insurance or through pandemic unemployment insurance as they've expended all their weeks, or they're no longer allowed to receive under the expended applications through PUA and the allowability. So we'll see applications increase at DHS. The last time that we saw an increase of applications at this level was in August of 2020 when the $600 per week surplus ended and folks were expecting to be able to go back on cash benefits. So what we did is we modeled the numbers off of those large application influx in August of 2020, and we mirrored them to straddle both October and November because the amount of time it will take us to find them eligible. The eligibility for PUA ends on September 6th, which is a little bit of an odd date, and we have a 30-day window to find people eligible. So we're expecting to see the cases on board in both October and November based off of what we saw in August of 2020.
Thank you.
I have a question about the how much loss in caseload you're attributing to DHS offices being closed to visitors. what's the service that's not being provided, and what's the workaround?
Right, so what the problem was is most of our applicants in the past would walk in with documentation to DHS and we would photocopy and or scan them immediately and they'd leave with a receipt. Right now we have drop-off boxes and we have ways to get documentation through to DHS through the customer portal and through the app. However, many of our folks need assistance with digital literacy and access to technology that will allow them to provide documents in a virtual way. If a client has documents with them in their home, they're not able to go and have them photocopied. Most of the libraries still remain closed. Most of our community action agencies don't have those services available. So what we've identified is there's a need for customers to be able to reach out to an individual agency and have some customer service based around getting those documentations to DHS. So Sharon, the numbers are a little bit confusing because the way that we identify a denial or a closure will include sometimes both pandemic unemployment insurance as well as failure to return documents. So what we notice is there's a 160% increase to not returning documents to DHS, but only a portion of that is attributed to not having income increased or unearned income increased as well. So we're servicing those individuals and we're reaching out to folks with either pending applications or are in the process of making better communication with folks if they have a community partner they can rely on to help get the documentation back to DHS if needed.
So would you say that's an ongoing problem or that problem has been solved?
It's ongoing. We're still working with our vendors to set up a smoother way to get the documentation not only to them and through digital format, but also back to DHS. So this is ongoing. I think we're making good strides and we have a good plan set up. We're working with alternative email addresses, virtual uploading, access to the customer portal. We've been doing trainings on that. It's just a difficult process. It's easier to work with folks that are already engaged with DHS and on an employment plan. It's harder to engage with folks that are in the process of applying where we don't currently have a relationship or a mechanism for communication.
So I guess two follow-up questions would be, when are you expecting the offices to open, and how does any of this factor into the uptick that you just described, which seemed to only be related to the end of pandemic unemployment insurance?
Yeah, we've seen a gradual decrease in Rhode Island Works even month over month, and we've projected a flat line from the March numbers forward. So we're actively working on getting folks that are applying to the benefit services so that we can find more people eligible. So we're hoping that the services we're providing are going to help maintain the March numbers moving forward, as opposed to having a decrease, which we've been seeing in the last few months, month over month.
Sharon, Governor McKee's team intends to work with each department on the reopening plan for each department. That's rolling out. So I don't have an answer in terms of when the offices will reopen. We do have drop-off service available in all the offices now, but to get back to a model of service where people can just walk in, it's still to be determined as to when that will happen.
Okay, thanks. I was just trying to figure out if that was cited as one of the major reasons for the drop-off, but not really seemingly factored into the uptick. I was trying to figure out how those things were related. Other questions? Joe, you all set? Okay, thank you.
Thank you.
Are you going to move on to the next?
Yes.
Okay.
So, Hannah's up.
Good morning. My name is Caitlin Molina. I'm the Deputy Director at the Department of Human Services. It's my honor and privilege to introduce you to Hannah Hansen, the Child Care Assistance Program Administrator. Obviously, I'm having a little bit of difficulty letting go of Caseload Estimating Conference, so I'm here to support her in any questions the conferees may have this morning.
Good morning. As Caitlin said, my name is Hannah Hansen. I'm here on behalf of the Office of Child Care at DHS, and I'm going to walk you through the materials our team submitted on behalf of the Child Care Assistance Program. So the section of these materials starts on page 24. As you'll remember, the child care sector experienced statewide closure beginning in March of 2020 through May of 2020 due to the pandemic. At that time, the state adopted several payment practices to support child care programs during the closure period and to support CCAP providers to safely reopen their programs beginning in June. It's important to note several of the payment practices. These flexibilities are ones that other states have provided to their CCDF programs pre-pandemic and are allowable under ACF regardless of COVID-19. The payment practices DHS established were reimbursing CCAP services based on enrollment, not attendance, waiving the allowable absence policy, and covering the cost of copays and CCAP provider payments during the mandated closure period. Upon reopening, DHS licensed providers were required to adhere to emergency COVID-19 regulations. With these enhanced health and safety requirements came additional costs due to new staffing needs to operationalize stable staffing plans and reduce group sizes, and the increased cost of supplies to support enhanced cleaning protocols. The CCAP payment practices first initiated during the closure period have stayed in place to support child care providers with the ongoing increase in costs associated with the pandemic. Additionally, as outlined on page 27, since reopening, CCAP providers have received a temporary rate enhancement. These flexible payment practices under CCDF ensure those enrolled in CCAP maintain their child care seat without fear of program operators prioritizing private pay families. Furthermore, the enhanced rate continues to support the increased costs associated with delivering care during the pandemic. As you know, the temporary CCAP rate enhancement has been approved by the Office of Management and Budget through June 30th of 2021. DHS has made 30-day commitments to these enhanced rates for CCAP providers in line with the governor's executive orders. It's the intention of our department to preserve these temporary enhanced rates along with the other CCDF-approved payment practices currently in place through December 31st, 2021, by leveraging the child care stimulus funding made available through CARES, CRSA, and ARPA. Beginning on page 29, you'll see a full breakdown of the department's CCAP COVID-19 initiatives. The anticipated costs and the funding source are also noted in the written materials we've provided. In addition to the continuation of the payment practices already in place through December of 2021, the department intends to leverage these funds to pilot a modified copay structure for CCAP families. This modified structure will reduce the maximum copay to 7% of a family's gross monthly income. Currently, these levels have a copay of 8, 10, and 14%. This approach will have a direct impact on CCAP families at an income level of 3 or higher in the CCAP regulations. The current copay structure for families at a level 0 through 2 will remain the same. Based on caseload numbers prior to the pandemic, it's estimated that this initiative would have an impact on roughly 1,024 children in CCAP each month. This pilot will be a key strategy in the state's broader response efforts to stabilize Rhode Island's economy and ensure families are able to successfully return to work without compromising their eligibility for public benefits. Additionally, less than a month ago, DHS launched a $17.9 million child care stabilization fund using CRSA funds. An additional $57 million under ARPA will also be leveraged under the current stabilization fund framework to issue ongoing stabilization grants to DHS licensed child care providers who are currently open and serving children. All DHS licensed programs, regardless of their participation in CCAP, are eligible for these funds. We're especially proud to share that Rhode Island was the first state across the nation to receive federal approval on our CRSA plan, which was developed in collaboration with our partner states across New England. The grants are being issued using a methodology that's consistent across the region, which leverages a classroom-based reimbursement model for center-based programs and a flat grant rate for family child care providers. To date, which is less than 1 month since the funds were made available, as Director Hawkins noted earlier, $2.32 million has been awarded in direct stabilization funds to child care providers. On page 31 of your materials, we've outlined the department's current and anticipated caseload estimates. You will see in fiscal year 21, group payment cycle 21, an average of 5,822 children were enrolled in CCAP each week. This number represents a 35% decrease in the enrollments from the same time period last year, prior to the onset of the pandemic. Similarly, there has been a 30% decline in the number of providers actively serving CCAP children. However, it's important to note that number does not represent provider closures. We've seen a very small number of actual closures. What we're seeing currently is a reduced number of CCAP providers with current enrollments as compared to 6 months ago, a trend that aligns with the current reduction in caseload. As noted on page 34, at the start of the pandemic in March 2020, DHS did not require attendance submission from CCAP providers due to the payment practice to reimburse providers based on enrollment rather than attendance. However, it was important for data collection purposes that CCAP providers resumed that practice of submitting attendance for DHS's review and approval. Beginning with batch 10 in October of 2020, DHS reinstated that attendance submission process for providers, which required them to submit attendance in order to receive CCAP payment. Since resuming the practice, an average of 20% of CCAP children are marked absent per batch cycle. This compares to approximately 4% of children enrolled in CCAP prior to the pandemic being marked absent. On pages 35 and 36, you will see that although reduced enrollment is expected to decrease the overall cost of childcare by approximately 16.2% in fiscal year 21 compared to the prior year, the rate per child is expected to increase by 29% due to the temporary rate enhancement. As I mentioned before, this enhancement will continue to support providers with decreased CCAP enrollments and increased costs associated with COVID. In fiscal year 20, the annual rate per child was $7,705. This is expected to increase to $9,882 per child by the end of fiscal year 21. The department is not projecting any fiscal impact due to the decrease in caseload given the practices in place to support the recovery and eventual stabilization of the sector over the next 6 to 12 months. Noted on pages 37 and 38 is an update on the SEIU 1099 collective bargaining agreement that expired June 30th, 2020. The state and union operated using an evergreen clause until a one-year extension to the CBA was executed in March 2021. The current agreement preserves the current policies through December 31st, 2021, and there are no scheduled rate increases for family child care providers at this time, as all providers are currently being reimbursed using the COVID enhanced rates. Finally, on pages 38 and 39, we have provided an update on the status of the state's corrective action related to the CCAP base rates. As you may remember, Rhode Island was placed on corrective action in February of 2019 for the provision of not meeting the equal access requirements of having sufficient rates. ACF requires states to have base rates at the 75th percentile of the most current market rate survey. If adopted, the fiscal year 22 budget will increase the base rates for all age categories to meet ACF requirements. The state has currently been taken off corrective action due to the temporary enhanced rates that are in place. However, if the fiscal year 22 rates are not adopted, Rhode Island would be placed back on corrective action once the current enhanced rate is no longer in place. On July 1st, 2018, DHS implemented a tier reimbursement rate system, as I'm sure you remember, for all center-based providers to support the increased reimbursement for high-quality programs. Included in the appendix materials submitted is a breakdown of the number of providers at each of the 5 tiers with information on the 14 programs that have increased their quality rating since October of 2020. At this time, due to the enhanced rates and the additional compliance associated with adhering to COVID-19 regulations, there's limited motivation for providers to pursue an increased rating. However, the department expects this to increase in fall of 2021. This brings me to the end of the CCAP portion of testimony, and happy to answer any questions you all may have at this time.
Joe, do you have anything?
No questions.
Okay. Steve? I have a couple questions. With respect to the 7% cap on copays, page 31, it talks about effective January 1, 2022, which is fiscal 22. And then later there's an estimate that the 6 months of that is 5.2 million. So that annualizes to about 10 million or so. Is this being applied, this $5 million increase, does that take into account the proposed rate increase in the governor's budget?
Sharon, I'll take that one. This is Caitlin. So important to note, there's two copay proposals leveraged in the caseload conference testimony. One is to waive copays for the remainder of the calendar year. That is the $5.2 million figure that you've referenced. Effective January 1st, which you're right, would be the next fiscal year, we are proposing to cap copays at 7%. We have not socialized that proposal with the provider rates. We are looking at the eligibility file for CCAP caseload, taking the average cost of those copays and the number of families served with copays above 7% to calculate the estimate.
Okay, sorry, you're right, I was referring to the wrong number. So the rate enhancement is the one you're pursuing through executive order, is that right? The
Correct.
6 months, and what's in the governor's budget is the sort of
The governor's
permanent.
budget rates will move the base rates to the 25th percentile, and it'll preserve the 5-tier at the 75th percentile for infant, toddler, and preschool age care. We have not yet introduced tiered reimbursement rates for school-age childcare.
Right, no, I'm trying to figure out, so you're saying that the copay caps shown here does not interface with the proposed rate increase. Is this based on, what is the base used for this copay cap?
The existing rates. So we hold the eligibility file for the child care caseload currently and took the subsidy cost of the 7% cap in copay. None of our caseload estimates include the proposed governor's rates.
Right, but if you were to cap the copay, it looks like that would be done administratively. Would it not increase the cost of the proposed rate increase if it's not assumed, you know what I'm saying?
I do know what you're saying. I think it would decrease because the COVID rates are significantly higher than the proposed rates in the governor's budget. So the share for the family would decrease and the department or the state's share would increase as a part of the cost per child. But the estimate provided in this caseload testimony is specific to the existing rates currently in effect.
Oh, so you're saying you calculated the copay cap at the temporary enhanced rates, which are also being waived effectively?
Correct, but we still know I'm sorry, yes. We still know what those copay calculations would be, so that was the eligibility file we pulled. We can easily provide an estimate of what the 7% cap and copay would be with the governor's new proposed budgets. It was my understanding that the conferees did not want caseload estimates in consideration of what is proposed in the governor's budget.
No, I'm just trying to figure out how all of these work together in terms of what's being done administratively or through emergency rules, and then what's actually before the assembly, what's assumed in the budget, and there's a lot of factors here. I'm just trying to track, and I know that if you cap copays after you raise the rates, there has to be some value to that.
Correct. If I may, I would just like to reiterate the only executive order, the only payment practice that is subject to the executive order right now are the enhanced COVID rates. And those are subject to the monthly executive order. The copay proposals all fall within DHS regulations. It was the hope of the department that we would bring transparency and budgeting perspective into that process by introducing it through caseload. So both waiving copays and capping the copay cost are subject to the DHS regulations, and we hold the departmental authority to do that independent of legislative action.
Right, but it is a significant dollar amount, so it's, at least we're aware of it. I would assume we need to budget for it. Anyone else have childcare questions? One other question. Anecdotally, I heard a provider was talking about how their enrollment had gone down recently and they were getting less money. And I was surprised because I know that you've been paying based on enrollment, non-attendance. People have gotten increased rates. And what I was told is that after a year, people started to not recertify. Is that what's happening?
So there's a combination of factors, but yes, most specifically to the CCAP caseload, we have seen a significant decrease in the number of families who are recertifying after a year of care. I would say that that has significantly gone up since the pandemic, but was an issue and something that we tracked prior to the pandemic. Most families, we did do some statistically valid surveying across childcare providers. Most families did not cite unemployment as their reason for not returning to care. It was that they've identified alternative care arrangements in light of the pandemic and have had parent nervousness in sending their children back to care. But yes, we have seen a significant decrease in the caseload, which is why we put into practice all of the payment mitigation strategies that we've introduced today.
So
the other thing, Sharon, is just depending on who the provider is, all of our mitigations to date have only targeted people making providers whole as it relates to subsidized care slots.
Yes, this is a provider that would be CCAP
okay.
mostly. Yeah.
Okay.
So, but parents can stay on, right? They don't get terminated. Is it now a year at least, right? If there's a change in circumstance.
It is a year, and we've most recently extended the unemployment clause for the CCAP recertification. So prior to the pandemic, we operated with a 3-month job search period after the 12-month certificate period. If families actively communicated with the department that they were unemployed but searching for a new job, we extended that clause to 6 months in light of the pandemic, and have added stuffer notices to all of our recertification packets, informing families of the importance of recertifying. In the light of being anecdotal, I would also share that we've been doing a lot of coaching with our childcare providers, that this is a family engagement issue 101. So there's a real need to communicate directly with families outside of state government agency, but there's a real need to communicate with families about the importance of recertifying and the importance of preserving early childhood supports and care and services for their children, despite what is currently in place with employment.
Thank you. If there's no other questions on childcare, we can move to your next group.
Hello, my name is Janice Cataldo. I'm the CFO for the Department of Human Services. The state supplemental payment projections begin on page 40 with the table on page 41. The state supplemental payment provides a monthly cash payment to individuals in need of a supplement to the federal cash payment. These supplemental numbers are usually around 33,000 persons and normally stable, only growing slowly each fiscal year. In fiscal year 2020, cases were increasing by about 100 per month for the first 6 months of the fiscal year prior to the pandemic. After COVID, though, cases dropped significantly. During the start of the pandemic, applications were coming in slowly. The federal field offices were closed and there was limited access to consultant medical exams, so cases declined. Cases dropped every month until the start of this fiscal year 2021 when they became stable. We project they will remain stable throughout this fiscal year. Our projections are that cases will begin to grow by November 2021 after the pandemic unemployment payments end, and despite projected economic improvements, because we believe there are potential applicants who have not applied. This pent-up demand is projected to be about 50 cases per month and will align both with the end of unemployment benefits and the opening of the federal field offices. This is not a significant growth, and our projections for fiscal year 22 are less than the actual number for both 2020 and the fiscal year 21 adopted number. The number of recipients getting checks by mail rather than direct deposit continues to drop and is outlined on page 43. Responses to questions on category F and the long-term care rebalancing initiative are on page 44. The assisted living 206 monthly payment begins on page 45. The state pays a 206 monthly state supplemental payment for individuals in an assisted living facility that is not eligible for Medicaid. These numbers have dropped from 161 cases in fiscal year 2018 to 69 and 63 projected for fiscal year 21 and for 22. We believe the drop in assisted living cases is due to some facilities being more selective, the closing of some facilities, and shifting of cases to alternative settings. That's the testimony on the state supplemental payment. Are there any questions?
Joe, do you have anything?
No questions. Thanks, Sharon.
I will then let my colleague Jennifer
hold on.
P., CPA, cover the general public assistance testimony.
Senate, you're good on, and we're good. Okay. Okay, go ahead. Thanks.
I'm Jennifer Pate, the Deputy CFO, and as Janice mentioned, a CPA. I'll be presenting general public assistance. The bridge information begins on page 47. GPA Bridge is a $200 monthly payment for those eligible individuals who maintain an active supplemental security income application with the Federal Social Security Administration. GPA Bridge numbers have been steadily declining each fiscal year in spite of overall SSI applications remaining stable. We project this decline to continue through the end of fiscal 21. The drop in bridge applicants accepted was due to improved eligibility standards for applicants and better income matches or interfaces. Our projections show the GPA bridge numbers beginning to grow when the requirement for the agency's medical assistance review, also referred to as the MART unit, ends in July 2021 and with the reopening of field offices. We are projecting a slight increase of bridge individuals from 62 to 66 in fiscal 22. The burial information is on page 48. The GPA program provides funds for funerals and burials for needy individuals and unclaimed bodies. Over the past fiscal years, burial costs have averaged around $630,000 annually. Due to COVID-19, we anticipated increases in the number of GPA burials due to COVID-19 deaths, the poor economy, and because of unemployment, more cases would need GPA support. In fiscal 2020, 4 families requested burial support for COVID-related deaths. The costs were shifted to coronavirus relief funds and are not included in the table. The total fiscal 2021 projected burial costs are $587,000, with 75 COVID burials through March 31st and 85 projected for the entire 21 fiscal year. We anticipate these COVID costs will be shifted to federal COVID relief funds this year as well. For fiscal 2022, our projections are aligned with pre-pandemic levels and show a limited number of COVID deaths. We anticipate a drop in overall Rhode Island COVID deaths and families finding the availability of FEMA funds a more attractive option for funeral reimbursement. Burial costs in fiscal 2022 is expected to return to pre-pandemic levels. That completes our testimony. Are there any questions?
Joe, do you have anything on GPA? Senate?
No questions.
No. Okay. We're good on that. Thank you. Do we have any general questions for DHS? Linda, do you have a question?
Caitlin had mentioned the 7% copay doing an estimate to the governor's budget, so I didn't know if we wanted any other follow-up from DHS on that.
I believe that is the only follow-up we have requested. That can come, obviously we don't need you to come back for that. I expect you'll get it to us when you have it. Are there any other questions for DHS? Thank you for waiting and efficiently completing your testimony. And let me say we will also all miss Janice if this is indeed her last conference. So sorry to see you go. Enjoy your retirement. Okay, we're ready to take on EOHHS, if everybody else is. And just a reminder to anyone paying attention, the EOHHS documents they'll be presenting from are also available on the General Assembly website. Again, the lower right quadrant of the homepage has the link to all of the May revenue and caseload estimating conference documents, so you can find them there. I think I'm going to turn this over to Ben Schaefer to get us started.
Thank you, Sharon. Good morning, everybody. My name is Benjamin Schaefer, and I'm the Medicaid Program Director at the Executive Office of Health and Human Services. I'm joined today by my colleagues Katie Alievich, Charles Plungis, Desiree Hodish, and Grant Porter. Before I turn it over to the team, I wanted to briefly highlight some important assumptions and summarize our overall testimony. As you are aware, we have seen significant growth in the Medicaid population due to the public health emergency. EOHHS has revised the November CEC estimate of the average number of Medicaid clients with full benefits from 333,649 in the current fiscal year to 325,293. Overall, we have seen an almost 9% caseload increase over FY 2020 levels. However, in the last few months, we have seen a slight moderation in caseload growth that is reflected in our testimony. For state fiscal year 21, we are projecting a $24 million all funds, $42.4 million general revenue surplus compared to enacted, for a positive variance of 4.5%. The last two times we have testified at caseload, we were grappling with making projections amidst significant uncertainty given the public health emergency. Thankfully, it appears that we see the wind down of the public health emergency in sight and more regulatory predictability at the federal level. At the end of January 2021, the Biden administration sent a letter to governors indicating their intent to continually renew the COVID-19 public health emergency declaration through the end of calendar year 2021, and that federal HHS will provide states with at least 60 days notice prior to the expiration of the public health emergency. Therefore, our testimony assumes that the 6.2% FMAP increase first initiated in the FFCRA will continue for the first two quarters, of state fiscal year 2022. It also assumes that we will be prohibited from terminating Medicaid members until the third quarter of state fiscal year 2022. Our testimony includes greater detail on the estimated net general revenue savings from the enhanced FMAP rate and the cost of non-terminations. While the predictability of the FMAP enhancement is welcome, it is important to note that the last guidance from CMS on how states could restart terminations and renewal activity following the public health emergency was promulgated under the previous federal administration. Our caseload testimony assumes that guidance will remain in force, but it is possible that the Biden administration will modify this guidance. At this time, we believe it will take a full year to fully catch up with renewals and terminations. Given the continued delay in terminations, EOHHS revised caseload forecasts for FY21 and FY22 are higher than prior caseload testimony. We are projecting a $3.3 million general revenue deficit in state fiscal year 22 compared to November caseload. I would note that Rhode Island's recent experience during the public health emergency has been consistent with regional trends per CMS data. From February 22 to September 2020, Rhode Island enrollment increased 8.8%, while among other northeastern states, including Connecticut, Massachusetts, New Hampshire, Vermont, and Maine, enrollment increased an average of 8.2%. So we feel comfortable with where we are in our overall caseload growth and projections. Before I turn it over to the team for a more detailed testimony, I wanted to highlight a few more items that are important to consider as we think about our collective recovery from COVID-19. First, given the potential for delayed care or more acute care given the public health emergency, there is more uncertainty around the managed care capitation rate increase of 3.5% assumed in our testimony than in previous years. Second, given discussion and confusion among stakeholders around the exact market basket increases under Rhode Island general law and the Medicaid state plan, in our written testimony we have clarified as best we can the baskets used for the conferee's confirmation and offered suggestions for additional clarity. Finally, One market basket requires particular examination at this time, and that is the home and community-based services market basket. Rhode Island general law specifies that we use the New England CPI for medical care, and the state plan, Medicaid state plan for home care hospice rate specifies the use of the New England CPI for medical care May release. This May release is not available until June, and as a result, we are not able to use this required market basket today in our testimony. However, given the effects of the pandemic on inflation overall during 2020 and into 21, that CPI index is showing negative 0% year-over-year growth as of February. Put another way, based on this index, we are forecasting a 0% increase for HCBS. This may not be what the law intended and does not take into account the pandemic's impact on inflation overall. Further, we know that the cost of home care, particularly labor, is rising and may not be fully captured in this index. We would ask the conferees in the General Assembly to think carefully about other policy options on a one-time basis in this area, given our collective focus on the long-term care system and expanding home and community-based services for Rhode Islanders. Thank you for your time. I'll now turn it over to the Medicaid Finance team to continue our testimony.
Can we just pause for any big picture questions? Linda?
Ben? Ben? Ben,
Yep.
if you could just kind of give us an explanation as to why the SPA state plan amendment differs from what is in state statute regarding the health care market basket?
It doesn't differ. It merely clarifies the specific time period that that Medicaid will use, so the May over May of the specific market basket that's in Rhode Island general law.
Okay, thank you.
Just again, a kind of a big picture question on, I did notice throughout some recommendations for the General Assembly to act. Certainly that's not the purview of the conferees. I'm just wondering, these were ideas that came up after the governor's budget was submitted or problems identified? Just wondering where that's incorporated into any of the recommendations from the administration.
We merely wanted to highlight the surprising nature of that CPI result, and quite frankly didn't want it to be, it is voluminous testimony, as you all know, and it would be something that's easy to overlook from a policy perspective. But as we were stepping back on our overall testimony and considering, what we were seeing overall from a caseload perspective, and from a provider perspective, simply wanted to highlight that discrepancies, particularly given what we hear from the community and what we hear from providers, and given the strange nature of the interaction of inflation during the public health emergency over the time period that we're seeing, and that's been written about, not just specific to caseload, but more generally.
Sorry, I think I was not just talking about home and community-based services. Obviously, that is a good point. It may be negative or zero, but there's several instances, I think, in the testimony where it refers to recommendations. That's kind of what I was talking about, a little more big picture.
Yeah, I'm not entirely sure which ones you're referring to. I'm sure that we can get that sort of as we move along. I think in my opening, as I've done the last couple of times, just given the unusual nature of the public health emergency, we like to highlight the kinds of questions or other considerations that conferees may want to take into account. Trying to speak from a little bit of humility, if you will, about our certainty.
All right, I guess we'll address each one as it comes up by item. Thank you.
All right, so hi everyone, my name is Chaz Plunges, Assistant Director of Finance of the Medicaid program. Can everyone hear me okay?
Yes, thank you.
I'm going to walk through the major development section of testimony. So in state fiscal 2021, EOHHS is projecting a $9 million all-fund surplus and a $42.4 million general revenue surplus. These represent favorable variances of 0.4% and 4.5%, respectively, against the enacted budget. In tables 2-1 and 2-2, we show the major drivers of variance. First, in table 2-1, the summary of changes to the fiscal 21 budget compared to the enacted level. And then in table 2-2, we show major changes to the fiscal 22 position compared to the November adopted level. Some of the larger variances in the current year, we have the enhanced COVID-19 FMAP providing the majority of the general revenue savings, combined with slightly lower than expected nursing home and hospice activity, NICU and sober births, as well as other fee-for-service activity. Additionally, we have some unbudgeted risk share stop loss variances. So they're, in the current year, we're anticipating gain share with the dental benefit. There's been a continued and constant decline in utilization, suppressed utilization of that service throughout both fiscal 2020 and 21. So that's a pickup there, and that's rolled into the risk share stop loss total in table 2-1. Some of the unfavorable variances that we're seeing, we have slightly higher capitation rates in state fiscal 21 than was assumed, both in November and subsequently in the enacted budget. Rates were finalized after November testimony. Major drivers to those changes were an increase in acuity of enrolled members that we had the actuaries were looking at as the year went on, and rates for state fiscal 21 weren't finalized until February actually of this year, so quite delayed, 6 months after the budget was enacted. Some other unfavorable variances include our rebates. We have lower than anticipated rebate collections, but across the 2 years, it's slightly moderated. If you look at just state fiscal 21, one of the bigger drivers for that deficit is the changing in treatment for rebate collections, which we'll get into more information later. But that is specifically related to prior period collections and improved understanding of how our fiscal intermediary is invoicing the manufacturers for those prior periods. So rather than, I'll get into the details a little bit later so we can move on. In state fiscal 2022, we have similar drivers in terms of the enhanced COVID-19 FMAP, which wasn't assumed at all in November. We have nearly $60 million in general revenue savings there, which is offset by increased capitation rates, which it trends the higher base forward into 2022. And additionally, enrollment is greater than enacted, or adopted rather. The last unfavorable variance in 2022 is DISH, which we restore to the unreduced allotment amount in 2022. Previously, the 2022 estimate included the reduced allotment. Are there any questions on the overall change in position before I move on to DISH?
Joe, do you have anything?
No questions.
I have kind of just, again, this is a little bit big picture on the rebates because I know it's like spread out, but last November, the rebates were part of your major big favorable variance, and now it's the unfavorable variance. Pretty big
Yep,
swings
so the-
here. We seem
there's the whole-
to...
There's a whole section on rebates that we're going to discuss in the next couple bullets, but I could jump ahead if you'd like. But
Well,
essentially, we
just big
work with our fiscal
picture, yeah.
intermediary. Yeah, so basically, last November, we assumed that we would be invoicing for prior periods, 8 different prior periods, all in fiscal 2021, and collecting all of that prior period activity. In discussions with the fiscal intermediary over the last few months, Gainwell, we've come to a better understanding of how they're invoicing for those prior periods. And so how it works is in March, between January and March, they invoiced for activity between October, November, and December of 2022. And with those invoices, they look at the 12 months prior to see if any new claims have come through for October, November, and December of 2019. And so how it'll work going forward is that every invoice will include the most recent 3-month period and then a year prior 3-month period. So we anticipate, rather than in November, we had assumed that they would be invoicing for all of those prior periods up into the current year. Basically that instead of receiving all of that prior period activity all in the current year, it's going to be spread out across the 2 fiscal years, because there's always like the 3-month period for the most recent quarter end, and then a year previous 3-month period with each invoice. And so basically what happens is we removed that large prior period collection from the estimate, and it's now rolled into the overall method and then spread out across the 2 fiscal years. That makes sense.
And from an accounting perspective, this is the right way to recognize the rebate? Or are we going to run into an issue there?
And that's a good question. The problem is we don't know with very much certainty what those prior period amounts are. So theoretically, under the accrual method, you should account for the prior periods in the period in which they're earned. But if we don't know those amounts with enough certainty, then I think we have a good argument to make for handling it the way we're now estimating it. But obviously, I could be incorrect, and the auditors may feel differently. But typically, you need to know with a fair amount of certainty what amount should be accrued in order to book it to that period.
Yeah, I think given the multiple changes we've seen on this item, as well as a lot of the changes we've seen on accruals over the past few years, it might be helpful if we just sort of run this past the auditors to see if this makes sense, or we're surprised by an adjustment later on, or now explaining a new methodology, which I'd love to avoid. Thanks.
We'll do that.
I think you
So
guys can
there's
move on. Yep.
No additional questions. I'll move on to just a quick summary of DISH. As I had mentioned earlier, the fiscal 22 estimate in November included 71 million all funds based on a reduced allotment. The Consolidated Appropriations Act of 2021 delayed those DISH reductions a number of fiscal years until 2024. And as a result, we're restoring the estimated DISH payment to the unreduced federal allotment in fiscal 2022. Overall, this results in a 70 million all funds increase over November adopted and the $32 million general revenue deficit. this section will be discussed in more detail in the hospital section, because I know there's a lot of questions about whether the enhanced FMAP and how the enhanced FMAP will be available for DISH based on changes in the recent federal legislation that was enacted, the America Recovery legislation. But I'll save that discussion for later, if that's okay. That's not for you. The next item of note is the opioid treatment program, specifically Medicare coverage for dually eligible members for those services. Starting last January, Medicare began reimbursing for OTP treatment, and UHHS subsequently modified our logic and MMIS to cost avoid for those services for dually eligible members. That fix to the system went live over the summer, and we collected just under $500,000 in recoupments from providers for the period January through June. And that recoupment is reflected below the line in our testimony in the current year. And then the overall reduced spending for that service is reflected in both years. In addition, the RHO managed care capitation rates included savings in both years to reflect the cost shift from Medicaid to Medicare for that service, for that particular population. The next item is the HIF, the health insurer fee moratorium and repeal. That health insurer fee was paid to the managed care plans in state fiscal 2021 and is reflected in our estimate. If you look at the actual payment, you'll notice that there is a difference between the value that we have paid and the value that we had estimated back in November. That difference is due to an error in our estimate where we didn't properly account for the after-tax treatment of the health insurer fee. So basically, we failed to adjust for the 2% gross premium tax on those payments. So it understated the estimated amount that would be due to the health plans. And so because we did that outside of the capitation rates, neither the state fiscal 21 or state fiscal 22 premiums include any adjustment for HIF that was paid outside of those rates. Section E provides an update on nursing home interim payments and recoupments. As you'll see from the table, we have an outstanding balance of just over $34 million. This compares to just over $85 million at fiscal close for state fiscal 2020. So we're collecting at a regular cadence those advances. And year to date, we have not provided much in the way of current year advances, so that number that's outstanding is declining more rapidly than it has in the past because there's less going out to providers. In addition to the nursing home interim payments, we included an updated table 2-4, which shows interim payments that were made along with recoupments and payments received to 3 different provider types. Those provider types being assisted living facilities, hospice providers, and home care providers. UHHS does intend to recoup those amounts shown in the table. They had been paused due to the pandemic. We delayed initiating those recoupments. Are there any questions on that section?
I have a question on the other LTSS provider types. You just said what it says here, and that is that you've delayed the recoupments. When will they be restarted?
I'm not actually sure. I don't know if Katie knows when the plan start is. She can speak to that, or I'll need to get back to you.
We don't currently have a scheduled start date for them. I think with the ongoing public health emergency and the impact to the providers, as we'll speak to some of the HCBS estimates later in the testimony, as well as the market basket concern that Ben mentioned. I think a number of factors will weigh in on the decision of when to begin the recruitment process.
Is there any expectation that we won't get this money back?
Not on the part of the state. I think our best estimate right now is reflected in this table, which aligns with what we had accrued for. There was a recognition with our accruals. Typically, we have to only accrue for what we can recoup back within 12 months, but the auditors agreed with us that it wouldn't be reasonable at the time of fiscal close to assume it would be within 12 months. So they allowed for us to make what they called a long-term accrual to recognize that we still intend to recoup the amounts, but over a longer period than 12 months. But we have, from the provider's point of view, again, as we'll talk about later, I think in the questions and answers portion, we've been making progress towards working with the providers and having, this is certainly on people's radars.
Okay, and just, I just want to confirm what it says here about the 10% of interim payments not being recovered. Is that what ended up in the final audited close? I know there were some adjustments to those accruals between the preliminary in September and the final. I just want to confirm that that's still what was.
We can confirm. Now that I will take that as a follow-up.
Okay,
I remember the discussion we had with you last time, but we'll confirm.
Thanks. Any other questions before they keep going? Okay, thank you.
So Section F discusses coverage for hepatitis C drugs. And as everyone knows, back in July 2018, UHHS modified the pharmacy benefit policy to allow all patients with documented hep C to receive coverage regardless of the stage of the disease. And based on the recent activity over the last number of months, in the last year really, we've modified our estimate of total expenditures to $7 million in state fiscal 21 and just over $7 million in state fiscal 2022. Since the change in policy, just under 1,100 members have completed treatment or are in the process of being treated. Last testimony, that number was about 1,000. So new members do continue to be treated every month. However, there still remains about 2,500 members with a diagnosis who have not received treatment. And based on the last couple of months and the relative stability in these expenditures, UHHS will be moving the coverage for this service in plan starting in fiscal 2022. So we will no longer be estimating this as a separate budget line. For purposes of this estimate, however, we did include the amounts separately so you can see what we're anticipating to include in the capitation rates, but ultimately, once we have the final rates, that will get rolled into the overall PMPM and it will no longer be shown separately. Figure 2-1 is just an illustration of the number of members in treatment by month, going back to July of 2017. So you'll see once the new policy came into effect, you'll see the spike in the number of members receiving treatment. That number has steadily declined and now is just about 40 or so members every month who are in active treatment for FC. Are there any questions on that section?
Looks like I can keep going.
The next section discusses the drug rebate and J-code estimate. We touched on this earlier, but this kind of gets into more detail regarding how the estimate was developed. Specifically, we looked at the period July 2020 to December 2020, which is the most up-to-date period that's been invoiced, coupled with the same period in 2019, as I discussed earlier regarding the prior periods. We take those invoiced amounts divided by average monthly managed care enrollment across the same time period, develop a PMPM multiplier by product line, and then we apply that PMPM to the revised forecast in both fiscal years. The result is that if enrollment differs significantly from what we assumed, we would anticipate modest changes to the overall level of claiming for rebates. And as you'll see in this exhibit, table 2-5, across the 2 years, we see that the $14 million deficit in the current year, all funds that I had spoken to in the introduction, which is offset in the second year by the $9 million surplus, which is attributable to both enrollment changes from November to the current, coupled with the change in the treatment of prior period activity. But as we had mentioned, we will discuss with accounts control and the auditor regarding the handling of the prior periods. The next section highlights the overall expenditures for the non-emergency medical transportation program. Since these expenses fall across a whole different set of budget lines, we consolidate them all here so you can see the overall change from the enacted level in each year. And one thing to note is that both periods include the enhanced PMPM that was added for to the rates 2 years ago now, consistent with the enacted level. And in 2022, the change in the PMPM year over year is based on the original RFP contract, which I think was a 3.3% rate increase year over year. So it takes the current rates and inflates them by the original proposed change year over year that was embedded in that initial contract. Are there any questions on this section?
No, I think you're good.
So section I discusses the PHE, public health emergency, and the enhanced federal matching rate and associated general revenue savings. Table 2-8 describes the various conditions that are in place in order to receive that enhanced rate. As a reminder, that enhanced rate applies to the regular Medicaid matching rate and the CHIP matching rate, but does not apply to expansion or other enhanced FMAPs, for example, the extended family planning FMAP, which is also currently at 90%, similar to the expansion FMAP. The big takeaway from this table is that the enhanced FMAP ends in the last day of the quarter in which the PHE ends. So if the PHE extends one day into the next quarter, we'll get that enhanced rate for the full quarter. So currently our estimate assumes December 31st, 2021 is the last day of the enhanced FMAP, but should that extend further, we'll get additional quarter of relief. And obviously along with that will become the additional costs associated with not terminating any individuals. That's what we'll need to weigh that at the time. The next subsection rather, illustrates the net general savings from the enhanced FMAP and also provides an estimate of the costs that would be incurred excluding the enhanced FMAP. So it's kind of takes, that's just in table 2-10, and it takes the February enrollment from 2020 as a snapshot and kind of assumes that that is the status quo during the whole 3-period timeline, so fiscal 20, 21, and 22, and takes the difference between February 20 enrollment and what we are now forecasting and the actual enrollment to estimate the additional costs, if you will, associated with that moratorium on terminations. It's not a perfect method, but it's kind of the best method that we have because we're not actively doing PEV, so we don't know how many individuals we're losing enrollment absent of the PHE. So this kind of approach takes a higher level look at the additional costs associated with the PHE and then weighs it against the additional GR relief. The difference between those two is about $165 million in relief, net COVID-19 FMAP enhanced relief across the 3-year period. Additionally, we show the estimated value of the enhanced FMAP each quarter. If that's in table 2-9, it's just under $33 million a quarter. That only includes Medicaid spending, does not include BCYF, DHS, or BHDDH. And depending on the expenses that are included in that, you can increase the value of that quarterly amount. For example, if we paid all of the UPL payments in a single quarter, that value would increase. Any questions on that section?
Go ahead.
So the next section discusses our caseload growth over the last year or so and how we develop the trends going forward for the remainder of this fiscal year and next fiscal year. As the director had mentioned in his opening statement, our enrollment increases have been on par with other northeastern states over the PHE period based on the most up-to-date data we have from CMS, which at this point is a little bit dated. But up until that point, we had been consistent with regional trends. We weren't an outlier anyway. Figure 2-2 illustrates for the Compre's full Medicaid beneficiaries eligible in the program. So it's not just managed care enrollment. This is all in eligibility for full benefit medical assistance. And it compares the November adopted value to our current forecast. And you'll see in the current year, we're trending below year to date where we thought we'd be, which is explains the portion of internal revenue surplus in the current year. And then you'll see in next year, we're above where we thought we'd be, since we're now assuming terminations cannot begin until January 1st, 2022. And for purposes of developing that trend, we took the last 3 months of actual enrollment growth month over month, annualized them, and reduced them by a third. So for any product where we were seeing month over month growth, we essentially carried that trend forward at a slightly depressed value. And that was to recognize that recently growth had slowed. So from February 2020 through really January, February timeframe, we had pretty significant month over month growth, which has recently declined, moderated somewhat. So we're now seeing less than 1% growth every month, whereas before we were seeing significantly higher monthly growth amounts. For any product where there was a negative trend, we assumed, and that those are specifically the ABD population, children with special health care needs, we assumed flat enrollment growth. So rather than continuing a decline in enrollment, we assume that enrollment would remain constant, which is consistent with the overall experience we've seen since the start of the PHE, which is shown in figure 2-3. So that figure shows the change in eligibility between February and March. And as you'll see, CSN and ABD groups are essentially flat, with slight growth of less than 1% in the CSN population, and rounded 0% growth in ABD. But overall, 142 additional members in the ABD population. The enrollment increases have really been concentrated in the expansion population and the children and families group. So those are the two categories of eligibility that are driving this month over month increase in this figure 2-2. Does anyone have any questions on that part?
Steve.
Thank you. Chaz, on figure 2.2, I assume the declines back in November, it was occurring, sorry, small print, it looks like end of February 2021 was the assumption. Is that terminations that would be taking place there? And then you're bumping that out to December 31st?
Oh, back in November? Yeah, so back in November,
where the graph declines, I'm assuming that's terminations showing up?
Correct. So in, are you talking about the blue graph, the current forecast or the November forecast?
Either. I was just trying to clarify that's what we were looking at. And then the slope appears to have gotten less steep in the current forecast versus November. Was there a change in the assumption of how terminations would go, or?
Yes, so back in November, we had assumed that the PHE would end on December 31st, and then terminations would begin March 31st. And then a third of the enrollment growth during the PHE period, which at that point was February to March, would decline over subsequent 3 months. And so that's the fairly rapid decline that you see back in November, which is that orange dotted line going from 342,000 members to 323. This year, in this forecast, we're assuming that the PHE ends 12/31. Because the Biden administration has committed to giving states 60 days notice before the end of the PHE, we're going to be able to terminate folks essentially as soon as the PHE is done. We'll be able to effectuate terminations. The prior estimate assumed a lag of 60 days to account for the normal lag between when the notices go out and when the member gets terminated. Is that 60-day period where they can respond with additional information that might continue their eligibility. And so the change in the slope is, back in November, we assumed 1/3 would come off over 3 months. And now we're assuming 1/3 over 6 months, starting in January. So more immediate start to the fall off in membership, but a slower decline in overall members. And there's a couple of reasons for that. The first being there's a much larger backlog now of members that we need to process. And so we anticipate we'll need, as the director mentioned, I believe, in his opening testimony, the full 12 months that CMS is allotted to clean up all of the activity. We're anticipating we'll need that time. And so the result is that in fiscal 22 at a higher place than we thought we would be back in November. Just over 10,000 or so members more.
All right, thank you. And you said that's what we're looking at is basically that 1/3 showing up in that first window. Did that third not grow in just by count because we've delayed redeterminations further? They look roughly equal, about 20,000 members or so.
Oh, from the 342 to the 320 and then 349 to 330. That's a good question. I'm not entirely sure why they would be so similar. I'm not sure others from the department have any thoughts on that.
Can you repeat the question? I think it's just the way the math, comes out to be that they're similar, like you stated, but I want to make sure I understood what you were asking.
It looks like it's roughly similar number of members that would come off in those periods, roughly 20,000. And I would have expected in the current forecast for, if you're still addressing 1/3 of the redetermination population, that number would grow a little bit more of just in count of members that would come off because it's a bigger pool at this point.
Yeah, so the peak's about 7,000 members higher, so that should add 20% of that on top of the previous, 33% of that on top of the previous total. We can take that back.
Okay, thank you.
Table 2-11 illustrates the current annualized trends for enrollment through March 31st. So we have the historical trend in the first column, which shows prior to the PHE, we had been seeing about a 4% reduction in managed care enrollment and a 3.5% reduction in overall eligibility prior to the PHE. Post-PHE, seeing 15.5% increase in managed care, but that's really distributed quite differently across individual products. So you'll see expansion, we've seen a 34% growth since the start of the PHE on an annualized basis, and Right Care Core 11%, with CSN and ABD groups exhibiting lower growth. And enrollment in RHA2 is actually down. The next column shows the trend between December in March 2021. And then the final is what we are forecasting through the end of the PHE on an annualized basis. So you'll see that the forecast on an annualized basis is slightly moderated from the experience between December and March, which we spoke about earlier. It's important to note that the same limitations that we discussed back in November apply here regarding using any macroeconomic indicators such as employment or economic conditions to predict short-term changes in Medicaid enrollment. As everyone knows, this recession has more greatly impacted lower-income earners than prior recessions. We have the MOE requirement that that was not in place during previous recessions that adds to the difficulty in comparing prior recessionary periods to see how enrollment might change. This is one of the first recession where we've had full expansion population in the mix. And so there's a lot of different things in those macroeconomic indicators that make it difficult to compare this recession to prior periods and use that prior experience to predict what's going to happen moving forward. The next page, page 20, we talk a little bit more detail about the methodology that we used at the end of the PHE, which I discussed earlier. And then we also highlight for folks on the bottom of page 20, we speak about the current batch of folks that we know would be terminated but for the PHE, along with the number of PEVs that will be run once the PHE ends. Just to give you a sense for the magnitude that's there. It's summarized a couple pages later on page 2022. We show the potential volume of terminations over 12 months. Obviously, the actual results will differ. By the time we run this process, there'll be greater number of shielded members. The renewals, the volume of renewals will be higher, et cetera. But this table of 69,000 on page 22 is just to give you a sense for the known quantities at this time in terms of who we could expect to be terminated. I will point out that the values shown for MAGI renewals, complex renewals, and PEV, those are all estimated based on prior periods. So we looked at the volume of folks who were terminated after running through the PEV process, the renewal process for both MAGI and complex, and applied those percentages to the current volume of members that are waiting in the queue to be run. This may or may not be a reasonable method for estimating this, but it's kind of all we really have available at this point. The actual volume of members terminated may be greater or less. Really, this remains to be seen. In the last section, we provide the conferees with a table on page 23 that consolidates our estimate, both the average monthly membership for full benefit programs, along with the average composite PMPM for those programs that you could then use to make changes to our forecast, if you so choose. Are there any questions on that? If not, I can hand it off to Grant, who will walk us through the managed care budget line.
Thank you. I think we're good to keep moving.
Thank you.
Good morning. I'll try to run quickly through each of the managed care sections, but I think Chaz did a really good job of sort of laying out the assumptions that are undergirding each of these sections. Beginning with managed care, our current estimate for fiscal 21 of $802.8 million reflects a $7.6 million deficit over the enacted. However, we're forecasting an $8 million GR surplus. For fiscal 22, our spending is expected to increase to $859.6 million for a $53.3 million deficit over the November adopted all funds and a $1 million GR surplus relative to November. Obviously, for both of those years, the difference between the all funds and the GR position is attributed largely to the benefit of the continued increased FMAP due to COVID. Overall, Chaz went into detail on the assumptions around how we drive these estimates. Again, we are taking actuals through March 31st. Either this week or next week, we'll have updated figures for April, just to give we can share those with the conferees, not expecting that to change our estimates, but just to give some firmer foundation of where we are year to date. Overall, however, our fiscal year enrollment of 880,000 members who are right care eligible is a reduction of 600 members compared to the enacted. This includes 158,000 enrolled in Right Care Core, nearly 10,000 in Right Care CSN, and 2,600 in Right Share. And there's approximately 10,000 remaining in fee-for-service. We've seen a decline in the number in fee-for-service as that figure generally captures a lot of the churn in our population as people lose eligibility and then return to Medicaid. And so with that happening to a much lesser extent, we're seeing a reduced number of people in fee-for-service, and you'll see that in our fee-for-service estimates for the managed care line. Overall, for fiscal 21, the drivers for the increase, the $7.6 million all funds increase, is due to increased enrollment in Right Care Core. Even though our overall children and family population is down by 600 members, our Right Care Core population is up by nearly 1%, 1,300 members. If you follow the managed care monthly reports that UHHS sends out, you'll notice that you may recall that the increase that we see month over month is almost exclusively amongst Right Care Core and Medicaid expansion, the MAGI-based eligibility groups. That has the benefit in that Right Care Core is one of our least expensive managed care programs, and Medicaid expansion, as we'll speak to later, is a 90-10 product. Another driver for the increase is the final capitation rates that Chaz mentioned that were finalized in February had a composite PMPM of $294 instead of the $286 that was assumed in November. The difference being attributed to changes in the relative acuity of the members per the final review of the experience by the state's actuary. Some savings for the current year are what we anticipate to be a gain share in Right Smiles based upon year-to-date reporting in that product line. It's nearly $5 million. And then, as I mentioned, lower than expected fee-for-service expenditures, particularly for the Right Care eligible population. We are seeing a reduction in the number of sober bursts and NICU stays for savings in the current year that carry forward into the subsequent year. The SOBR expenses and the NICU expenses both are expensive. A SOBR at birth is a bundle payment for the delivery of a child in right care. It's approximately $13,000. The average NICU cost is approaching $50,000. And so a slight change in the number of NICU stays and or births could have a meaningful impact. So we're estimating a decline in the number of NICU births, and this is derived as a percent of NICU stays that we've seen through October. And so we're using fairly old data in order to capture this estimate, but that's a necessity due to the time lag in which we get those claims. So just to be aware, we are seeing a reduction based upon the same methodology that we used in November, but a slight change of another 50 births leading to a NICU, which would be 1% of our births. So certainly within the some moderate confidence interval could lead to a $1 million swing plus or minus in that budget line. But we are reflecting some overall reduction due to the methodology that we've used in the past. Overall, I won't repeat this for every budget line, but to summarize, the savings that we're getting as a result of COVID, the increased funding, and the change between what we saw in November. So, for example, in managed care, we're assuming $47.1 million in additional GR relief. This is $11 million increase over what was assumed in the enacted. Any questions on the current year? Moving on to fiscal 22.
You moved on too quickly. My question is on what I've seen a lot of in the testimony, and it starts with the managed care, and that is the final certified capitation rates, including an acuity adjustment, raising the composite rate. In the case, this is what it says in the case of managed care. Can you speak to this acuity adjustment that seems to be in a lot of the 2021 rates, please?
Yeah, I can begin, and Chaz can back me up when necessary. So the rates for fiscal 21 are derived from fiscal 18 and fiscal 19 experience trended forward. In the interim, we had two things that happened that have offsetting, but also could be exacerbating impacts. One is, if you recall, pre-COVID, we were seeing a steady decline in our enrollment, quite drastic, up until February. That likely led to healthier people losing eligibility, thereby increasing the relative PNPM of those who remained. And we saw that the result of that leading to some significant risk share payments in fiscal 20. Subsequent to that, with COVID and the increased enrollment and potential for pent-up demand and higher acuity as a result of illness specific to COVID, led to the actuaries considering the relative acuity in the current fiscal year compared to what was reflected in the fiscal 18 and fiscal 19 baseline. So the base data never changed, and they're using that to set the rates, but they have to price them relative to the expected acuity of the enrolled population during the rating period. And as more information was learned about the effects of the pandemic and looking at experience across states of how the pandemic was impacting the relative acuity and costs in the current year, they thought it was prudent to make those adjustments, given that the rates had not been finalized back in November or July.